Hey there, good afternoon. We're going to be getting started with Crystal, who will be talking about red blood cell transfusion in critically ill patients.
Don, can I start or do you give him a half minute? Okay. Hi guys, I'm Crystal Alexander, and today we're going to talk about red blood cell transfusions in the critically ill patient. So we have three, looks like a lot on the slide, but there are three big objectives. We're going to discuss the relationship between red blood cell transfusion and clinical outcomes. We're going to look at the evidence for red blood cell transfusion thresholds in specific populations. And then we're going to look at the general approach to a transfusion reaction. So we'll start off with the TRICC study and kind of to give us some context. So in the 1980s, like transfusion reactions started becoming more of an issue, I guess, and more of a highlight, particularly because at the time you had the rise of HIV infections, the rise of like hepatitis. And so at that time, people were concerned about transfusion risks. In the last like 2 decades or so, like that has shifted more to think about transfusion benefits and specifically also our resources. So RBC shortages that we've been dealing with. And so the shift is less from risk and more about what are the actual benefits of transfusions. And so the TRICC study had 2 major aims, which is to quantify the incidence of anemia and red blood cell transfusion practices in a critically ill patient population, and then to examine the relationship of anemia and red blood cell transfusion to clinical outcomes. So this was a prospective multi-center observational trial, and it occurred across 284 med-surg ICUs across 213 hospitals in a total sample population of 4,892. And just kind of give you some baseline characteristics of the population, this was truly a critical care population. So if you kind of look at this table here, there was 61% of them were mechanically ventilated, 7% had a mean ICU length of stay, 7 days ICU length of stay. Hospital length of stay was about 13.2 days. ICU mortality of 13%, hospital mortality of 18%. So this was the sick population that we were interested in following. Overall, 44% of patients were admitted to the ICU. Who were admitted to the ICU received 1 or more transfusion of red blood cells specifically. Now, if we're looking at what the most common indication for transfusion was at that time, 90% of them, it was for a low hemoglobin level. And looking at our 2 graphs on my left, you can see that longer ICU stay was associated with a higher percentage of patients being transfused. I don't know what happened. I'm sorry. Not today. Oh, no. Okay. So longer ICU stay associated with a higher percentage of patients being transfused, and then more mean units being transfused as well. Of this, 4% of the total transfusions resulted in some form of a complication, the most common being fever, hypotension, and fluid overload. So on our left, table 11, so this kind of walks us through the length of stay, I want to focus particularly on ICU length of stay and hospital length of stay and its association with transfusions. So as you can see, the number of red blood cell units transfused was significantly associated with increased ICU length of stay and increased hospital length of stay. The baseline hemoglobin level was not statistically significant, did not have a statistically significant association. And looking at table 12, we're looking at a 30-day mortality in these patients. And again, kind of just to draw your attention to our red boxes, red blood cell transfusions were independently associated with mortality, and as well as a nadir hemoglobin less than 9 was associated with an increase in mortality as well. So after adjusting for propensity for receiving blood transfusions, what they found was that red blood cell transfusions were independently associated with an increase in mortality. So kind of to bring us to the bottom line, what did this trial tell us overall? So anemia was common in a critically ill patient, and it tended to persist throughout their ICU stay and their hospital stay. And then it was an independent, blood transfusions rather, was an independent risk factor for morbidity and mortality, for ICU admission, and for hospital length of stay. So that brings us to the TRICC trial, transfusion requirements in critical care. So the TRICC trial came about looking at whether a restrictive versus a liberal approach was better for the patient, essentially. But the specific population that they looked at were critically ill patients with euvolemia after initial treatment. So let's say the patients came in, they were resuscitated, they were found to be euvolemic, and then they could be included in the trial. They couldn't have a hemoglobin level greater than 9 at that time either. And so this was a randomized control trial across 25 different centers. The restrictive strategy specifically, so they were transfusing to a hemoglobin level less than 7 was their threshold. And then they were trying to maintain the patients between 7 to 9. So that was their intervention. And they were comparing it to a liberal strategy. So the threshold at that time was a hemoglobin less than 10 and a target range between 10 to 12. And their primary outcome was all-cause mortality at 30 days. Obviously, they had a number of secondary outcomes, but no trial is ever powered to a secondary outcome. I think what's important to learn, to kind of note about this population, they excluded any active bleeders, which you would argue a lot of what we see in our ICU are GI bleeds. And so we'll get to trials focusing on that at some point. But I think that's important. They also excluded brain death patients and pregnant patients. And their sample size, even though it's large enough, 838, that is actually only 13% of the total patients that they screened. So it whittled down quite a bit. Now, looking at a primary outcome of death, all-cause mortality within a 30-day period specifically, you could see that it was 18.7% in our restrictive strategy group, 23.3% in our liberal strategy group. And as you could see, this was not statistically significant, right, when you're comparing the two groups. Now, these are our Kaplan-Meier curves, which kind of talked to us about survival. For all patients, there was really no significance in survival between the two, if you're looking at just all the patients collectively. But when they did some subgroup analysis, they saw that patients with an Apache score less than 20 and those who were younger than 55, actually there was a survival benefit. Now, I would argue that that is probably a less sicker patient. If you have an Apache score less than 20 and you're younger than 55, it's odds are you're not as sick as if we're talking about a true critical care population, right? But there was some survival benefit that they saw, or difference in survival, I should say. Now, another thing that this study looked at were a number of complications and adverse events. So in terms of cardiac events, specifically including myocardial infarction and pulmonary edema, these were more frequently occurring in the liberal transfusion strategy group during their ICU stay. And I think it's also important to note that even though you found this in this population, when you looked at in table 4, this little my little box at the bottom here, you could see that there was no significant difference in the rate of cardiac events, the rate of infectious complications, pulmonary events, or multi-organ failure in these patients within 48 hours preceding their actual death. So when it comes down to the bottom line with the TRICC trial, what it showed was that a restrictive transfusion threshold was at least as effective as, if not possibly superior to, a liberal transfusion threshold in critically ill patients with normal volemia. So again, patients who are not actively bleeding. There was a trend toward decreased 30-day mortality among patients who were treated according to a restrictive transfusion strategy, but this was not statistically significant. And there were significant differences in hospitalization mortality rates of cardiac complications, and rates of organ dysfunction favoring restrictive strategy. So then we came to the TRICC trial, transfusion requirements in septic shock. So when, again, TRICC was looking at normal volemic patients, right? So now you have people who are in septic shock. These are your unstable people. This is the specific population that you're looking at. And just for like some context, so this trial was done in 2014. In 2012, at that time, the surviving sepsis guidelines were recommending that you transfuse patients up to a hematocrit of 30 or a hemoglobin of 10 if they had hypoperfusion within 6 hours of them presenting to you, right? So at that time, like surviving sepsis was saying, let's go for a higher goal, but trials were slowly coming out showing like, well, a higher goal may not actually be beneficial. And so the TRICC trial was trying to address that specifically. So they were trying to look at the mortality of leukoreduced blood transfusions at a lower, so restrictive threshold versus a higher hemoglobin liberal threshold among patients with septic shock. So this was a multi-center randomized control trial. Again, the thresholds were 7 and 9, and their primary outcome was death by 90 days after randomization. And of course, they looked at a few secondary outcomes as well. And this trial occurred across 4 European countries, I believe. So looking at our primary and second, well, specifically the primary outcome, which was death by day 90, there really was no statistical significance comparing the lower threshold versus the higher threshold. And then even if you look at our secondary, outcomes, looking at specifically vasopressor and ionotropy use, mechanical ventilation, renal replacement therapy, those also were not statistically significant between the two.
I think this was really important because when you think about early goal-directed therapy, right? If you think about the physiologic basis of why a hematocrit of 30 or hemoglobin of 10 came into place, was really about maximizing oxygen delivery. And the most efficient way to do that, you either have to increase cardiac output or you have to increase oxygen carrying capacity, which was hematocrit. And so before the TRICC trial came out, there was some question as to whether or not actually transfusing to those higher goals would be appropriate. And this actually sort of, showed that there was no increased mortality, if you will, by a more liberal transfusion schema. So it didn't necessarily debunk that guideline. And we'll see more as we kind of.
Yeah, and so Dr. Rivers. Yeah, so Dr. Rivers brings up a point, which I was going to get to. But yeah, so the SCVO2 in the two groups was basically similar. So like he's suggesting, did these people really need blood, right?
No, they didn't.
So one thing that actually I just wanted also to mention was the restrictive strategy. I don't think it's on this slide now. The restrictive strategy actually reduced blood transfusions by about 50% in this particular trial, this patient population. And so that was statistically significant. So even though there was a primary outcome of mortality, like again, like I was talking about in the beginning, people were starting to think about red blood cell transfusion shortages. Is there a benefit to this? Is there a way we can supply demand kind of issues? So on my left, we have the Kaplan-Meier curve, which basically just reiterates that survival time didn't differ significantly between the two groups. And then on my right, we're looking at the relative risk. So your tiny boxes are like your relative risk, the long lines are your confidence intervals. And even when they kind of grouped them between age 70, greater than 70, less than 70, whether or not you had chronic cardiovascular disease, and also SAPS. So SAPS stands for Simplified Acute Physiology Score. It's basically like a severity score, essentially. So essentially, were they more severe or less severely ill, right? Even with that, there was no statistical significance. So bottom line of your TRICC trial, patients with septic shock who underwent transfusion at a hemoglobin threshold of 7 had similar mortality at 90 days, but they used 50% fewer units of blood compared to those who underwent transfusion at a hemoglobin threshold of 9. And in terms of your secondary outcomes, your rate of ischemic events, your use of vasopressors or inotropy, need for mechanical ventilation, renal replacement therapy, all of those were similar between the restrictive and the liberal strategy groups. So there's some cases embedded. I would love it if you guys could participate. So this is our first case. It's a 55-year-old man is evaluated in the ED for hematemesis. He has had intermittent epigastric discomfort for the past few weeks that does not vary with meals. He doesn't smoke, he doesn't drink alcohol, and he's not on any chronic meds. He is hemodynamically stable with the exception of a heart rate of 110 per minute. And his physical exams are unrevealing. His labs show that his hemoglobin is 8, his platelet count is 130,000, and he has a PT of 10 seconds. So crystalloid resuscitation is initiated and he undergoes an EGD. It shows an 8-millimeter duodenal ulcer with a clean ulcer base without active arterial bleeding. Which of the following is the most appropriate management? Would you opt to continue crystalloid resuscitation? Would you give packed red blood cell transfusions? Would you give a plasma transfusion or would you give a platelet transfusion? Crystalloid, okay, all right. And so we're going to talk a little bit about where some of the data for transfusion strategies in acute upper GI bleed comes from. So this particular trial also looked at again, restrictive versus liberal transfusion strategy for acute GI bleeders. This was patient population, this is a randomized control trial occurring across Spain. Again, our target values was a hemoglobin less than 7, trying to maintain post-transfusion between 7 and 9. And in a liberal group or liberal strategy, a hemoglobin threshold less than 9, trying to maintain between 9 and 11. And their primary outcome was mortality at 45 days. And just of the patients that presented with upper GI bleed, peptic ulcer disease was the top reason with about 49%, followed by gastroesophageal varices at 24%. It's also, I think, important to note that all of the patients that were placed in this study, so they actually, within 6 hours of admission, they all received an EGD, which you could argue, Dan just said, wow, right? So you could argue that doesn't really happen in real life, right? But every patient in this study received an EGD within 6 hours of admission, and they also received EGD with intervention. So if they had, whether it was variceal or non-variceal, whatever they saw that they could manage, they did. So just for context. Sorry. Yeah. So looking at our, can I move this? Looking at our Kaplan-Meier curve, so what they did was they just kind of brought the graph inset for us. It's the same curve. But you can see that 6 weeks or 45 days, the probability of survival was significantly higher in your restrictive strategy group compared to your liberal group. And among all the patients overall, so looking at subgroup analysis, so overall, all patients with cirrhosis, the risk of death was actually slightly lower in your restrictive strategy group. But if you looked at the subgroup analysis also, looking at your patients with class A or B Child-Pugh scores, the risk of death was actually significantly lower among the restrictive group also. In terms of the study outcomes, so again, we talked about death from any cause within 45 days. So what the restrictive group, 5% of patients versus the liberal strategy group, 9% of patients. And this worked out to a hazard ratio of 0.55, which essentially tells you that 45% relative risk reduction in all-cause mortality at 45 days, favoring your restrictive strategy. There was also, regarding this restrictive strategy, an associated shorter length of stay, as well as fewer adverse events, which, sorry, they looked at quite a few of them, and fewer rebleeding events, particularly among patients who were suspected of having esophageal varices. So our bottom line for this particular trial, the risk of further bleeding, the need for rescue therapy, and the rate of complications were all significantly reduced, and the rate of survival was increased with the restrictive transfusion strategy. In patients with an acute upper GI bleed, a strategy of not performing transfusion until a hemoglobin concentration falls below 7 is a safe and effective approach. We got a question. These patients were largely portal hypertension, increased red cell increases portal pressure, and worsened bleeding. Yes. So we have another case. Early administration of tranexamic acid, or TXA, has been shown to not alter short-term mortality in which group of patients? Any takers? B? Yeah. Yeah. So the main focus of the presentation is red blood cell transfusions, but I think because we get so many GI bleeders, I think that TXA kind of should be something we discuss just briefly. And so we know that data exists for TXA in postpartum hemorrhage, in certain TBI patients, and in trauma patients. But what about in your GI bleeder, right? So the HALT-IT trial tried to quantify the effects of TXA on death and thromboembolic events in acute GI bleeding. And so this was a double-blind randomized controlled trial occurring across 15 countries, and they utilized TXA, 1 gram loading dose followed by 3 grams maintenance dose over a 24-hour period as their intervention, with a matching placebo as their comparator. And the primary outcome that they looked at was death due to bleeding within 5 days of randomization. So, so as you can see, death, specifically focusing on death due to bleeding within 5 days, comparing use of TXA versus placebo, there was no significant difference between the two. If we also looked at, also look at the effect of TXA on death due to death with subgroups. So time to onset, bleeding location, variceal or liver, and the Rockall score. Again, there's no significant difference. There's no preference between use of TXA versus a placebo. What they did also look at were complications involved. So what they found was that TXA was actually associated with increased risk of venous thrombotic events, as well as increased risk of seizures. And so kind of the bottom line was TXA did not reduce death from GI bleeding, but was associated with an increased risk of venous thromboembolic events and seizures. And although this trial cannot entirely rule out a modest increase or decrease in death due to bleeding with TXA, it can rule out large mortality reduction suggested by prior Cochrane review. So there is a prior trial, there's a trial prior to this that showed a large reduction in mortality. And there was some question about the trials that were included. So they were very small trials, I think 7 in total, if I recall. And so this trial was in an attempt to see, well, is there truly a mortality benefit? So we have another case. A 2015 trial compared 2 massive transfusion strategies in patients with trauma and hemorrhagic shock. Fresh frozen plasma, platelets, and RBCs given in either a 1:1:1 ratio or a 1:1:2 ratio. Compared with the 1:1:2 ratio, patients receiving blood products in the 1:1:1 ratio strategy had which of the following? Higher incidence of transfusion-related acute lung injury, higher mortality at 30 days, lower mortality at 30 days, less exsanguination and death at 3 hours. See? Any other takers? Sorry, I don't have a poker face. Any other takers? D, yes. D, yeah. You guys said that in the beginning. I know, I heard it. So where does that come from? So we're going to talk about the proper trial. So this study was done to determine the effectiveness and safety of transfusing patients with severe trauma and major bleeding using plasma, platelets, and red cells in a 1:1:1 ratio compared with a 1:1:2 ratio. So it was done across several sites. It's a randomized controlled trial. And again, the ratios were 1:1:1 versus 1:1:2. And their primary outcome that they looked at was 24-hour and 30-day all-cause mortality. They also, of note, for their secondary outcomes, they collected quite a bit of data on complications. A total of 23 complications were included. So what they found was that there was no significant difference in mortality at 24 hours, nor was there any significant difference in mortality at 30 days with the ratios. Now, when they looked at cause of death, particularly exsanguination, exsanguination was predominant cause of death within the first 24 hours, and it was significantly decreased in your 1:1:1 group. And is it here? Yeah, 9.7% versus 14.6% with a difference of 5.4%. And it's not here, but the p-value was 0.03. So statistically significant. Now, when they looked at the complications, again, they looked at 23 complications in total. So, if you're getting like a 1:1:1 ratio, you're going to receive more plasma, you're going to receive more platelets over the time course. But despite that, there were no differences between the two groups for any of the 23 complications. Even when you looked at like ARDS, multi-organ failure, venous thrombosis, transfusion-related complications, no difference.
Does anyone know if our massive transfusion, what our ratio is?
1:1:1, yeah. Mm-hmm.
That's what I assumed.
So bottom line for the proper trial, among patients with severe trauma and major bleeding, early administration of plasma platelets and red blood cells in a 1:1:1 ratio compared with a 1:1:2 ratio did not result in significant differences in mortality at 24 hours or at 30 days. However, more patients in the 1:1:1 group achieved hemostasis and fewer experienced deaths secondary to exsanguination at 24 hours. Even though there was an increased use of plasma and platelets transfused in the 1:1:1 group, there was no safety differences identified between the two groups. So your cardiac population. So the cardiac population, there's been a ton of trials. This is only like a subset of them that have been done. It's a lot to go through, so I kind of just try to summarize them. And mostly, I think the reality trial, the most recent one in 2021, is probably what would be most important, thinking about an acute MI in a critically ill patient. And so they compared a restrictive transfusion threshold with a hemoglobin less than 8 to a liberal threshold of a hemoglobin less than 10, and they found that it was non-inferior. And they used a 30-day MACE. So MACE was major adverse cardiovascular events. So this would like include stroke, recurrent MI, need for emergency, like revascularization. It was kind of like a composite score. So, and we have another case. A 53-year-old male is evaluated for tea-colored urine. He reports no other symptoms. He was hospitalized 2 weeks ago with melena, upper endoscopy and colonoscopy at the time did not show a bleeding source, but he stabilized after the transfusion of 1 unit of blood. He was discharged 10 days ago and he returned to work. Medical history is otherwise significant for trauma sustained in an MVA about 5 years ago, requiring multiple surgeries. He takes no medications. On physical exam, he's afebrile and vital signs are normal with no posterior blood pressure or pulse changes. He has scleral icterus on exam and his stool guard test result is negative. The remainder of his exam is unremarkable. Which of the following is the most appropriate next step in the management of this patient? A direct antiglobulin test or PUMS test. B, flow cytometry. C, repeating his endoscopies. Or D, transfusion of 1 unit of blood. And he has some labs in the little box here. He has 10 days ago, his hemoglobin was 8. Now on presentation, it's 6.9. His Billy's 10 days ago was 1.1. Now his total Billy is 5, and he has a direct Billy of 0.7. And he has a UA with 4 plus blood, 2 to 3 erythrocytes per high power field, and 1 leukocyte per high power field. Okay. All right, yeah. All right, so this brings us into transfusion reactions. So transfusion reactions can be kind of grouped into acute versus delayed by time, or if they're immune mediated versus non-immune mediated. So in your acute immune mediated period, you're going to have acute hemolytic transfusion reactions, febrile non-hemolytic transfusion reactions, urticaria or hives, anaphylaxis, and TRICC. If you're looking at non-immune mediated, you could have cold toxicity, citrate toxicity, sepsis, and TACO. Under your delayed grouping, immune mediated, you can have delayed hemolytic transfusion reactions. You can have transfusion associated graft versus host disease, and you can also have post-transfusion purpura. Under your non-immune mediated, you could have iron overload and viral infection. So due to time issues, we will not go through all of these, but there are a few that I think are important for us to look at, and we'll go through them with cases. So in terms of our general approach to a transfusion reaction, you're going to first obviously elicit symptoms. So the patient might have fever, chills, they might appear flushed. You might notice that they're icteric. At the transfusion site itself, there might be pain or swelling. Or you can have it on the other side of the spectrum where they're floridly suddenly in shock and they're hypotensive, oliguric. So the first thing that you would do would be to stop the transfusion, stop the insult or the offending insult. Always remember your ABC. So airway, breathing, circulation. You check their vital signs every 15 minutes and you do a clerical check. Clerical check, we'll talk about it when we reach the Henry Ford protocol, but essentially you're checking that the blood that was given to them was actually like they had a a cross match. So yeah, appropriate cross match. You're checking that what was sent up to be given was actually given, and you're also gonna on the back end, if you think it's a transfusion reaction, you're gonna take samples from the patient, right? But you're also going to take the blood that came up and send all of that down to the lab. So if you suspect that they have a reaction, again, you're going to get a sample from them. You might also get a UA. So if you kind of triaging things, so if you suspect that they have hemolysis, you want to confirm that, right? So you're going to get Billy's, you'll get an LDH on them, you'll get haptoglobulin, you might get a peripheral smear. If you think this is like a shock-like state and they're septic, you're going to do a gram stain, get blood cultures, and you should be blood culturing both the patient as well as the product, which is why it's so important, like not to have the product dumped out. It needs to go back to the lab. And if you suspect Charlie versus Taco, we'll talk about that as we go on, but you're going to be on your physical exam. Do they look hypervolemic or versus euvolemic? Do they have crackles in the lung fields? Are they JVD up? You're going to get an ABG, portable chest x-ray, and a BNP. So this is a case of a 78-year-old female. She's hospitalized from an outpatient infusion clinic for progressive shortness of breath. She was receiving a transfusion of 1 unit of blood. She reports no chest pain, cough, dizziness, or palpitations. Medical history is notable for heart failure, hypertension, and myelodysplastic syndrome with symptomatic anemia requiring transfusion approximately every 3 weeks. Her medications are low-dose aspirin, metoprolol, lisinopril, HCTZ, and something I cannot pronounce. On physical exam, her T-mass is 36.7, blood pressure is 153 on 76. Pre-transfusion, she was 123 on 71. Heart rate was 94, pre-transfusion 65, respiratory rate is 32, and pre-transfusion it was 20. Her oxygen saturation is 85% on room air. She has GVD of 10 centimeters of water. Her S3, she has an S3 present on exam, and she has bilateral crackles heard on your pulmonary exam as well. So you get a chest radiograph and it shows moderate pulmonary vascular congestion with a small left pleural effusion. Which of the following is your most likely diagnosis? Is this an acute hemolytic transfusion reaction? Is this an anaphylactic reaction? Is this transfusion-associated circulatory overload? Or is this transfusion-related acute lung injury? Takers? No? C? All right. So let's talk about TACO first. So TACO is correct, transfusion-associated circulatory overload, characterized by any 4 of the following occurring within 6 hours of completion of transfusion. So acute respiratory distress, tachycardia, increased blood pressure, acute or worsening pulmonary edema on your chest x-ray, and evidence of a positive fluid balance. And so usually you'll get a BNP, and if it's elevated, it kind of just supports your diagnosis. Now, TACO actually affects like 1 to 8% of your transfusion recipients. And there are some like risk factors that are associated with TACO. So patients who are older in age, patients who have any pre-existing cardiac disease or renal disease, patients who received multiple transfusion products in the past, which our patient has, and if you're transfusing at a very rapid administration rate as well, that increases your risk for developing TACO. So how do we manage TACO? So you're going to diurese the patient and you're going to offer supportive care essentially. And well, you would have stopped the transfusion, I would hope. Yeah. So sorry. Yeah.
Like in heart failure patients, I assume their DMP and then more time to ramp up for chronic issues. Would you see it rise soon after transfusion in pencil patients, or does it take time for you?
I'm not sure, like if you're looking for like a number, I don't have a number for you, but there you will see a rise. Yeah. So trolley, but sometimes it can be a little difficult to differentiate between the 2 of them. So transfusion related acute lung injury. So for TRALI, you need to have acute lung injury, which in and of itself is described as being acute onset, hypoxemia with a P over F less than 300 or oxygen saturation less than 90% on room air, and other clinical symptoms or other clinical symptoms of hypoxia. You'll see bilateral infiltrates on chest x-ray, which you could also see with TACO. And you'll see no evidence of left atrial hypertension. So these patients shouldn't be in circulatory overload, essentially. It shouldn't be volume up. Additionally, they should not have any pre-existing acute lung injury before transfusion. And TRALI usually occurs during or within 6 hours of transfusion. There should be no temporal relationship to an alternative risk factor for acute lung injury. And so the alternative risk factors for acute lung injury are actually very extensive. So essentially they're saying like you should have ruled out all these other things before you call it TRALI. And they also have criteria for like possible TRALI, which essentially you're not quite sure about the temporal relationship to any of the alternative risk factors that you're considering.
Yeah, the best way to think of it is ARDS that develops.
So I kind of put this table here to just help us differentiate between the two, because a lot of times especially in like questions that I've come across, like TACO and TRALI, I kind of pitted against each other. So looking at your features or parameters on the left and then comparing the two. So body temperature, you can have a fever with TRALI. Blood pressure in TRALI tend to be more hypotensive. In TACO, they're more hypertensive, which goes with kind of like their volume up state. Respiratory symptoms, obviously they'll both have acute dyspnea, neck pain, so you're checking for JVD. In TACO, it can be distended. When you auscultate, you'll probably get rales, crackles with both, but in TACO, you could also get an S3 on your cardiac exam. Looking at the chest radiograph, it may not be super helpful because you can get diffuse bilateral infiltrates in both. When you look at the EF of the patient, it can be normal or decreased in TRALI, and in TACO, it most commonly tends to be decreased. Your PA occlusion pressure would be 18 millimeters of water or less. In TACO, it would be greater than 18. Your pulmonary edema fluid, if you happen to tap them for whatever reason, you'd get an exudate with TRALI, and you'd get a transudate with TACO. Your fluid balance could be positive, even negative with TRALI. In TACO, they're usually very positive. The response to a diuretic, again with TACO, would be significant. You can see transient leukopenia with your TRALI patients, and in TACO, this should be unchanged. Like their white cell count should remain relatively the same. BNP, again, TRALI, oh, there is a number, I'm sorry. Here's your number. Yeah, sorry. So TRALI less than 200. So TRALI is generally less than 200, TACO greater than 1200. And your leukocyte antibodies, which your donor leukocyte antibodies would be present in TRALI, and you'll have cross-match incompatibility between the donor and the recipient. Versus TACO, they may or may not be present, the leukocyte antibodies. Right. So our next case is a 60-year-old male with a history of refractory Hodgkin's lymphoma that has been treated in an academic medical center 3 hours from his home with second-line chemotherapy. He now has persistent anemia and thrombocytopenia. He presents to the ED in the rural hospital in his hometown with fatigue, weakness, and a one-day history of melena that began 2 weeks after starting ibuprofen 800 milligrams TID for his back pain. His white cell count, 1.65 with 78% PMNs. His hemoglobin is 6.7. His platelets are 78. Essentially, he's pancytopenic. He gets admitted. He gets a PPI, and he receives 2 units of packed RBCs. The next day, he has an EGD, and it shows a 2-centimeter gastric outlet ulcer. Patient is discharged from the hospital the following day, feeling like he's back to his normal self. He comes back 1 week later, and at that time, he's acutely ill appearing. He has profuse diarrhea over the past 3 days. His Tmax is 39.1, blood pressure 148/82, a heart rate of 104, and a respiratory rate of 16. He has marked pallor of his conjunctiva. He has an erythematous maculopapular morbilliform eruption. that he says was initially pruritic and began over his face, ears, palms, and soles. It is now also present on his upper trunk and abdomen. White cell count is 1.22 with 83% PMNs and 5% BANs. Hemoglobin is 7.2. His platelets are 64, and his retic count is 1%. Bilirubin is 3.1 with an indirect of 0.6. What is the most likely cause of this clinical presentation? Is this a reaction to a newly started PPI? Is this Pseudomonas bacteremia on the basis of neutropenia? Is this Yersinia intercolitica associated transfusion infection? Is this transfusion associated graft versus host disease? D? Okay. Yeah. So what made you think it was D?
The time frame, the other associated symptoms with it.
Yeah. So this is like the best board question you could ever get. Everything was in there. So the rash is very characteristic. Erythematous maculopapular morbilliform eruption. Also his history of having a lymphoproliferative disorder, the chemotherapy as well, specific chemotherapy agents increases their risk. And then kind of like why the others aren't right. So PPIs actually can give you like a delayed hypersensitivity reaction, but I mean, it's not that. Pseudomonas bacteremia on the basis of neutropenia. So the patient actually was not neutropenic that they gave that to us, unless I missed it. And generally the rash, so if he was to have a rash, it would be like ecthyma gangrenosum. So it'll look different. Yersinia enterocolitica associated transfusion infection. So he doesn't quite give you the picture of septic shock, right? Like bacteremia. He's not hypotensive. He's not super tachycardic. And then you have all this other information that basically is telling you, hey, this is like graft versus host. So we're not going to go through this whole table, and we've kind of gone through most, but I wanted to put it up here for you guys to be able to refer to later on, because I thought it was kind of handy to just kind of have everything here. The things that are going to help you delineate what the primary reaction is, or what the reaction is, will be kind of how they present, particularly timing. And then obviously treatment is almost the same for most, in terms of the first thing you always do is obviously stop the transfusion reaction, right? Stop the transfusion that's occurring. Kind of indirectly talked about sepsis, talked about Charlie, talked about Taco, talked about the big ones. And in terms of delayed transfusion reactions, so you have delayed hemolytic, you have transfusion-associated graft versus host disease, which we talked about. One thing to note is with that, you would prefer to give them irradiated products, right? The other one that I came across that actually is like very rare is post-transfusion purpura. So these patients usually present within like 3 to 14 days. They have purpura, mucocutaneous spleens, and they have like a significant thrombocytopenia on presentation, generally less than 10. And basically they have these like HPA antigens, and they form antibodies to that. So you can test for the antibody as well. It's very rare, but when it happens, these are like really sick people, and your first line treatment is to give them either IVIG, and second line would be Plex. So blood product modification. So just to kind of touch on, so we know like when should we give what, right? So washed red blood cells, this is a unit of PRBCs that are washed to reduce plasma proteins, and it reduces the risk for an allergic transfusion reaction. It reduces immunoglobulin, so particularly like in your patients with like IgA deficiency, this would be somebody you would want to give like washed red cells to. For leukocyte reduced red cells, so red blood cells and platelet units are filtered to remove most of the leukocytes, and this actually reduces your risk for a febrile transfusion reaction. It may help prevent alloimmunization to HLA and donor antigens, and it also can help reduce your risk for CMV infection also. So if you have like an immunocompromised patient, this might be someone you might consider it in also. Irradiated blood, we already kind of talked about. The main one for that would be if you suspect like transfusion-associated graft-versus-host disease or think the patient is at risk for it. And then just kind of briefly to talk about our transfusion protocol here at Henry Ford. So you can find this on 1 Henry under policies. And it kind of, everything that we've kind of talked about intermittently. So the policy basically highlights what are you looking for if someone is going to have, like, if you're going to suspect a transfusion reaction occurring. So the common things: fever, chills, they're having respiratory distress, do they have any abdominal flank pain? Look at the site itself. Is there any pain at the site, skin manifestations, whether at the site or like systemically, like urticaria, hives, etc. Icterus, nausea, vomiting. You're going to also look for oliguria and changes in blood pressure. Now, in terms of the management, they have like a very specific way that it's to be done by the nurses, but in general, kind of take home points: stop the transfusion reaction, don't throw away the blood, get a sample from the patient and a sample from the blood, and bag everything up and send it to the lab. And so that brings me to my take-home points. So blood transfusion is an independent risk factor for morbidity and mortality, for ICU admission, and for hospital length of stay. There's no difference in mortality between a restrictive and liberal transfusion strategy in patients with septic shock. However, a restrictive strategy favors use of 50% fewer units of blood, which reduces your risk of adverse outcomes. A restricted transfusion strategy, as compared with a liberal transfusion strategy, improves outcomes among patients with acute upper GI bleeding. Among patients with severe trauma and major bleeding, early administration of plasma, platelets, and RBCs in a 1-to-1 ratio compared to 1-to-1-to-2 favors hemostasis and fewer experience death due to exsanguination by 24 hours. And transfusion reactions can be acute or delayed, and in some cases may be prevented by use of modified blood products, including liquid-reduced and/or irradiated blood products. And that brings me to the end. I'd like to thank Dr. Kinney for his assistance with this presentation. And I kind of welcome any questions you might have.
An excellent talk for the series I was in here for. But in terms of the septic shock, treat as a transfusion, a restrictive versus liberal. The study that looked at that, if you look at the SUDO2.
Yeah.
We
Yeah, that's okay. We can talk about it again.
Is he already here?
No,
He dropped that bomb and left?
Yeah.
All right, well, that's all I had.
Okay. All right.
Oh, see, he's like,
yeah, this is like from above. Does hemodynamic phenotypes matter? In terms of, can you elaborate a little more? Can you hear me?
Okay.
Hmm? Oh, are they? I don't. How do I do that? I'm not techie.
Yeah. Chris.
I'm only here to present.
No,
I
it's
don't
just
do
these
anything
speakers
else.
are like,
Broadcast to the speakers.
yeah.
Yeah. See the bottom there, what's going through. Yeah, so you should be getting sound. Oh, on the Zoom, you have to make it. Yeah, so yeah, there we go. Okay, so speaker. So yeah, try that one. Yeah. So now we might be able to hear them.
In terms of offering.
So low. What's the problem? I don't know if you'll hear him. Sorry.
You're asking like in terms of like whether to use like a liberal versus restricted transfusion strategy, depending on like the hemodynamic phenotype. Oh, increased lactate, hyperdynamic, etc. Sorry. So I'm not sure exactly how to answer this, but just going
Okay.
off base of the
It's like from.
hello.
Yes, can you hear okay?
Yes, I can hear.
Yeah, when you get a patient with EF of 20%, a hemoglobin of 6, SVO2 of 30, a lactate of 6, that's different than a patient with a lactate of normal hemoglobin of 8, etc. So when you look at all these studies and you're combining different hemodynamic phenotypes, that basically tells you the need for blood because you want to deliver oxygen. That's your main goal. So are we being too what can I say, general in terms of classifying patients? Because there are patients that need blood that are what we call tissue hypoxic patients, and perhaps the groupings that we see in these large scale studies don't give us that specificity.
I see your point, and I totally agree. It's definitely very dependent on the patient that is right in front of you. I think the trials are just it's good to have that data and it's good to have that knowledge, but you have to put it into context of the patient in front of you, essentially.
Yeah, one thing about equivalence trials, and you got to be careful, the reason why they do equivalence trials is because they can't do prospective randomized trials because there may not be equipoise, or the ethic of it may be bad. So they'll do a trial, they'll say we can get away with this, but they didn't say that it's the right thing to do for all patients. So you have to be careful when a trial is called what they call an equivocal trial. What they're basically, they can't do a prospective randomization, and that's the great difference in interpretation. But in general, if you look at that article about hemoglobin strategies and sepsis, and you read the appendix has some very interesting information that didn't make it into the manuscript. But also, if you look at the train of letters that came back to the editor, they asked them specifically, why didn't they look at these patient populations? And they didn't have an answer for it. So I think that sometimes great publications, even though they're large randomized trials, they may not necessarily be asked a specific answer. It may overall decrease transfusion rates, but there are pockets of patients, especially when you get these real sick cardiomyopathies that get septic, that can't mount their cardiac outputs when they go into septic shock, and you wonder why it's because they have limited abilities to deliver oxygen, and those people perhaps may need a little more help than others. But excellent lecture though.
Thank you.